Alright guys, still pretty sick. Woke up really congested today, but doing my best. And excuse me for having to sneeze over and over, but thankfully I did get some good sleep. Probably gonna have to start antibiotics because this feels very bacterial. Yesterday we were able to finish up block 3. Today, within the next 3 hours, I should be able to wrap up block 4. And then I'm thinking from Saturday, let me see. Yeah, Saturday the 19th, I'll start doing NBME 18. I'm going to start working on explanations the next 3 days. And then 19, 20, 21, and 22, I'll use those 4 days to wrap up NBME 18 explanations. Because a lot of people were asking about it, and apparently it was pretty high yield, so we'll see. Alright, let's get started with this. So right here, we're in block 4 now. Yeah, thanks a lot, guys. Oh, shit. Okay. So we finished everything from up to here. This is where we left off yesterday. Block 4. Number 1. 21-year-old man comes to a physician because of a 1-month history of fever, abdominal pain. He also has had a 15-pound weight loss during this period. They didn't tell you where he's from. Okay, he's a consultant to non-governmental organizations that support organic farming. Alright, he returned from a 2-month trip to the Middle East 3 weeks ago. Temperature is high, 102. Physical exam shows generalized lymphadenopathy and hepatosplenomegaly. Lab studies show pancytopenia, which is pretty much the giveaway for which one of these acid choices you're going to pick. The most likely cause of these findings is an organism belonging to which of the following genera. So now, when you look at all these acid choices, all you need to figure out is which one of these causes pancytopenia. For example, trypanosoma, like Trypanosoma cruzi, right? That's the one that causes Chagas disease. That does not cause pancytopenia, so you wouldn't pick it. All the different schistosomas were related to like biliary tract or bladder cancer, so that's not going to cause pancytopenia. Plasmodium, like Plasmodium falciparum and all the other different plasmodia, they cause malaria, which also does not cause pancytopenia. And Acinetobacter, let me find that real quick. Acinetobacter was a gram-negative, oxidase negative. Yeah, I don't even know too much about Acinetobacter. I'm just looking it up on Google real quick, and it's just a bacteria, but I don't know what it really causes. I mean, you could tell it's a bacteria because Acinetobacter, but what does it cause? What does it cause? Clinical significance. Let's see. So Acinetobacter, clinical significance, nosocomial infections in the ICU, hospital-acquired pneumonia, ventilator-associated pneumonia. This is the ventilator-associated pneumonia, VAP, definitely worth knowing. Can also cause otherwise infections, but definitely not pancytopenia. So this was leishmania, right? The patient has Kala-Azar. Kala-Azar includes spiking fevers, hepatosplenomegaly, and pancytopenia. The others do not cause pancytopenia. This man's fever is super high, and his history of travel to the Middle East, organic farming, and his physical exam all fit leishmania. So if you forgot leishmania, Sketchy did a really good job with them too. What did I put? 163. So right here, give me a second. Leishmania. So right here, this is the thing this guy has, right? And he's presenting with Kala-Azar. Okay. So this is Kala-Azar is actually like the name Kala Azar is coming from some African thing. I forgot what Azar meant, but Kala means black, and this is like a black something. Spiking fevers, hepatosplenomegaly, pancytopenia. You can also get cutaneous leishmaniasis, which would really just have skin ulcers. Now, you do need to know leishmania because both trypanosoma and leishmania are pretty significant. Trypanosoma is more high yield. It pops up a lot more on exams, mostly because of the dilated cardiomyopathy that's related to. But as far as leishmania is concerned, this is the sketchy micro image for leishmania, right? You can see the amphibians that are all over the place for amphotericin B. You have the goats to remind you of the amastigotes that you can see inside macrophages, which is why they're inside of cages, right? Those are goats that are inside cages to represent amastigotes inside macrophages. And the things that you're seeing here, of course, the cow with the liver and the spleen, the hepatosplenomegaly, and then this down here, that's for the treatments, stibogluconate, right? So that's steak right there. Stibogluconate is the other treatment. And around this guy, you can see there's a bunch of flies flying around because you need to remember the sandfly, right? So pretty much everything that's on first aid, you need to remember it. And Sketchy Micro's image for leishmania did a really good job showing it to you. All right. So make sure you remember Kala Azar. Do not forget Kala Azar. And this question was pretty easy because they gave you the pancytopenia, and even if you didn't remember leishmania, the others are pretty significant, and you should remember them, and you should be able to understand that those other guys are not related to pancytopenia. Find Myself here is asking about dealing with forgetting past subjects that you study. That's actually a really difficult thing for many people, right? When you're studying something, maybe you just studied like cardiovascular and then you went into endocrine and you forgot some of the cardiovascular things you looked at. I feel like there are different ways of solidifying how to memorize what you study. One thing I talk about a lot, one thing I talk about all the time is repeating things to yourself without the book in front of you. For example, we just talked about leishmania, right? So now that I'm done studying leishmania, like I just studied it, I would close everything, so I don't have leishmania open. First aid isn't open now, right? And then I would talk about it. Okay, so leishmania causes Kala Azar, which has spiking fevers and pancytopenia. It can also have cutaneous ulcers. It's going to have amastigotes inside macrophages. And stibogluconate was one of the treatments. Otherwise, amphotericin B is the other treatment. And this kind of repetition of material without having the material in front of you is critical, right? Being able to talk about something without looking at it in front of you is one of the most significant things that helped me memorize topics, because oftentimes when I would be streaming, I didn't want to, go open up something to look at it and then tell you guys. I kind of wanted to be able to tell you guys what I'm looking at straight from my mind, and when I started doing that, I realized that really is one of the most significant ways of memorizing something. Other things, of course, you can do, every time you finish a chapter, do U-World questions on it. Every time you see something in another chapter that might be relevant to a different chapter. For example, when you're going through GIT, you find a lot of ammonia stuff that's relevant to stuff you see in biochemistry, like the urea cycle and hyperammonemia and stuff like that. You should revisit it, right? So repetition is the other thing I always say, very, very key. Doing repetition has been one of the second most significant things to help make sure you can actually solidify what you're trying to memorize. So those are the things I would say. Okay, so going back now, number two. Number two is actually a pretty cool question. This one you do need to make sure you remember. This is from immunology. So which of the following pairs of drugs interferes with DNA synthesis by cross-linking, right? Which is also similar to intercalating or alkylating. You need to remember that. So you need to know all of these medications, of course, and for drugs that interfere with DNA synthesis, lomustine and cyclophosphamide, cancer drugs, Right? Lomustine is a nitrous urea that cross-links DNA and can cross the blood-brain barrier to enter the CNS, so it is used for brain tumors. Cyclophosphamide is a nitrogen mustard that cross-links guanines and is used for solid tumors like leukemias, lymphomas, and rheumatic disease like lupus and granulomatosis and polyangiitis, but adverse effects include SIADH and hemorrhagic cystitis. Remember also that whenever you give someone cyclophosphamide, you also give them Mesna to avoid the hemorrhagic cystitis and possible bladder cancer. Another alkylating agent that cross-links DNA includes busulfan, while procarbazine has an unknown mechanism and is used for brain cancer. So if we go to 475 over here, it's really important to make sure that when you get to this part, right here, the cancer drugs, right, make sure that you can sit and look at this image and talk about each one of these medications from your mind. Talk to me about their mechanism, talk to me about their side effects, and make sure you understand that majority of drugs all work at the synthesis phase. Right, you can see all your antimetabolites work here, all your topoisomerase inhibitors work here, and G2. The only medication that's specific to G2 is bleomycin, right? And then mitosis uses microtubules, so all your microtubule inhibitors are over here. Right, then there are some cell cycle independent drugs, and those are alkylating agents, and that's kind of what our question was about, right? Cell cycle independent drugs. They work at any point. It doesn't matter. They don't really have anything to do with the cell cycle per se. Alright, so make sure you do know these medications really well, and chemotoxman at the end kind of helps you remember some side effects. Right, you remember some side effects from it, but not everything. This is still very good though. It's very good, and when you're on this page, you should also, again, be able to mention these medications, talk to me about their side effects, and if there's anything you can do to avoid them, like for cyclophosphamide, as we just said, give Mesna, right? Number 3, a 78-year-old man is found unresponsive in his yard by a neighbor. Paramedics arrive and begin resuscitation. 25 minutes later, he regains a stable cardiac rhythm. He's brought to the emergency department and mechanical ventilation is initiated. His temperature is 97.5 F, pulse is 76 per minute, respirations are 14 per minute, with spontaneous respiratory efforts. And blood pressure is 98/60. So he's really old and he needs resuscitation. He remains unresponsive. After the patient is admitted to the hospital, his neighbor says he always said he would not want to be kept on life support if there was no hope of recovery. His wife died 5 years ago, and I've been cooking for him and helping him with errands since then. The patient has no children or close relatives. The physician believes that the patient has sustained significant anoxic brain injury and his prognosis is poor, right? Because this patient has not been getting enough oxygen to his brain, and within a minute of low oxygen to your brain, you pretty much are brain dead. It is most appropriate for the physician to state to the neighbor, which of the following at this time? So what would I say to this neighbor that just told me what this patient always used to wish for? Well, first of all, understand that this patient, this old 78-year-old man, has no one on this earth, right? No wife, no kids, nothing. He doesn't have anything besides this neighbor. So this neighbor is the most significant family member for this guy. Now, this significant family member told me something, so I'm going to thank him, right? And when you look at all your answer choices, A, the hospital lawyer must be consulted. Immediately, you just write that off as a no because that's not something you really do. Since the patient has already been put on life support, he will have to remain on life support. That's not true, right? You could put people on life support and take them off. D says, thank you for your concern, but since you are not a relative of the patient, you cannot make decisions for him. That's rude, first of all, right? Second of all, he is a relative now. At this point, he's the closest thing that the patient has to a true relative, okay? Because the patient doesn't have any other true relatives at all, any blood relatives. And then E, unfortunately, your friend is brain dead, so there is no need to make life support decisions at this point. That is just, that's a dumbass answer. It makes no sense at all. C was the best choice to go with. Thank you for telling me this. Your friend's previous statements to you can be very helpful in making decisions for him, which is very true, right? And that's all you had to work with. I mean, a lot of people, when you get questions like this, you know, it's very easy to convince yourself into thinking something else was correct. Make sure you're picking the nicest answer because people are very sensitive, and always pick something that makes the most logical sense. The most logical sense. Number 4, an 8-year-old boy is brought to the physician by his mother 6 days after she noticed a lump on the left side of his neck. He is at 75th percentile for height and weight. Physical exam shows pectus excavatum. There are two 2mm subcutaneous nodules on the lips, an irregular 2 by 2.5 cm mass on the left side of the neck, and anterior cervical lymphadenopathy. His 14-year-old sister also has similar findings at the age of 10 years. Which of the following studies is most likely to support the diagnosis? So, pectus excavatum was one of the things that should help you remember Marfan. Alright, so when we go to Marfan real quick, let me see, where was that? Try to remember where Marfan was. Oh, okay, here we go. Yeah. So these two things, right? Pectus carinatum and excavatum. And remember that pectus carinatum is more specific, right? Pectus carinatum is more specific to Marfan, but pectus excavatum is also something you see in Marfan syndrome. So this little boy, this 8-year-old boy, has some kind of Marfanoid habitus. And then they tell you he has subcutaneous nodules on the lips, which are weird, right? Almost nothing causes that. So those are mucosal neuromas. And then the mass on the left side of the neck is most likely related to his parathyroid, because the thyroid wouldn't really just be on one side. It wouldn't be unilateral. So altogether, this is kind of starting to seem like it might be men's syndrome, which is autosomal dominant, and that's why his 14-year-old sister also had similar symptoms, findings. She probably also had multiple endocrine neoplasia. So this patient has oral ganglion neuromatosis, mucosal neuromas, which are both only seen in 2B. The pectus excavatum is specific for Marfan, a habitus associated with the red oncogene. This patient definitely has been 2B, and you would have to check for serum calcitonin concentration to pretty much confirm the diagnosis. Right? That's really all that's happening there. So when you need to memorize men's syndrome, you can either memorize it or put this on your cheat sheet. That's basically it. Right? Either one of them. You could put this on your cheat sheet too, the original, something that the older first aid had, or whatever the new first aid has, whatever you need. But personally, I would just write pituitary, pancreas, parathyroid, thyroid, pheo, and mucosal neuroma, where the last 3 and the first 3 go together, and then you know that parathyroid, thyroid, and pheo are for men 2A. Right, but our guy has men 2B. He has medullary thyroid carcinoma, he has pheochromocytoma, and he has mucosal neuromas. Right? He has the Marfanoid habitus we just needed to see, right? Because of the mutation in the red oncogene, and that's pretty much all you needed for him. Now, it is also possible that a similar question can be provided for men 2A, but the subcutaneous nodules on the lips were the thing that were the giveaway for men 2B. So always be on the lookout for that. Serum calcitonin concentration would pretty much resolve whatever issue. Like, that would give you your diagnosis, and that's it. The other answer choices don't make any sense. Dexamethasone suppression is for Cushing, antithyroid is for thyroid, serum TSH is also for thyroid, and then TSH hormone receptor antibodies also for thyroid. So you can pretty much understand all those other things being related to thyroid, and you should probably know them. TSH receptor antibodies, right? That's like Hashimoto kind of thing right there. Not even Hashimoto, no, actually that's Graves, right? Antibodies against the receptor would be Graves, where you actually activate the receptor rather than destroy it. But either way, you should understand none of that would be related to him. Number 5, this was a cool question. So a 2-week-old girl is brought to the physician by her parents for a well child examination. Physical exam shows an asymmetric left pupil. Ophthalmologic examination shows a coloboma of the left eye. Incomplete closure of the embryonic fissure that is limited to which of the following structures of the left eye is most likely to spare this patient's vision. So basically, what would spare the vision? That's basically all you're really trying to figure out here. And then your answer choices are a long list of different parts of the eye, right? So coloboma is an eye abnormality that occurs before birth. They're missing pieces of tissue and structures that form the eye. colobomas affecting the iris, which results in a keyhole appearance of the pupil, generally do not lead to vision loss. Colobomas involving the retina result in vision loss in specific parts of the visual field. Large retinal colobomas, or those affecting the optic nerve, can cause low vision, which means vision loss that cannot be completely corrected with glasses or contact lenses. So the only thing to pick was the iris, right? And this was really weird. This is a weird ass question, because for most people you don't really know what a coloboma is. So, you go ahead and Google that shit. Coloboma is an eye abnormality that occurs before birth. Right? You can kind of see it right there on the bottom, that black portion right there. There are missing pieces of tissue in the structures that form the eye. Right? So weird. Such a weird, rare thing. And this is a real case right here. Right? You can see how it looks. You've probably never seen this before. Right? But that's the kind of shit NBME likes picking on. Shit you've never heard of before. And this image does a pretty nice job showing you the real eye versus, the cartoon image that we're always looking at. And any coloboma that would spare the iris, you can see that's the part that pretty much gives you the color of your eyes, right? If you spare that, you should be okay. Right? So they asked you incomplete closure of the embryonic fissure that is limited to which of the following structures of the left eye is most likely to spare this patient's vision. So if the coloboma really only affected the iris, basically, right? Colobomas affecting the iris results in a keyhole appearance of the pupil, and you would not have vision loss. And you can see the keyhole appearance they're talking about right here. So basically, like, that is like a keyhole right there, right? That's exactly how most keyholes look like. This is also like a keyhole. Alright, so what the main lesson here is that if the coloboma is only affecting the the iris, then vision will be okay. Remember that the iris's job is really only color of your eyes. That's it. That's pretty much the most significant thing that the iris is responsible for. Okay. And if you look at all the other parts of the eye in this question, you can understand that affecting any of these, choroid, lens, macula, optic nerve, and the retina, affecting any of these other parts will affect vision. That was another way you could tackle the question, right? All of those other parts are related, even the choroid, because the fluid in your eyes, the aqueous humor, needs to move correctly for vision to work. Otherwise, you can get glaucoma, which also affects vision. And we just did ophthalmology in neurology recently too. That's really important to remember that. Coloboma, though, not a really high-yield topic. It's just NBME picking on it. Number 6, a 2-year-old girl is brought to the physician because she is cross-eyed. Alright? Physical exam shows moderate strabismus. If not treated, she will most likely have deficits in depth perception due to lack of appropriate competitive interactions in the visual cortex. Calcium entry through which of the following receptors mediates the outcome of this competitive process? Let me just check something real quick. So apparently I did not write an explanation for this question. The explanation that there is online is just really, really long. But this is apparently a tough question because people haven't really learned receptors that well. But this student got it right. Right? Because neurotransmitters and their receptors are a difficult thing. She's cross-eyed, moderate strabismus, deficits in depth perception due to lack of appropriate competitive interaction in the visual cortex. Calcium entry through which of the following receptors mediates the outcome of this competitive process? Well, at the end of the day, though, calcium entry would really just be related to one of the two, right? It's either going to be GABA or NMDA. That's definitely one thing you need to know. Glycine is more relevant for hyperammonemia. We saw in hyperammonemia you had to use up a lot of your ammonia to make glycine so you could get rid of your ammonia. Serotonin is also irrelevant here, right? Calcium entry does not have much to do with that. And metabotropic glutamate also does not have anything to do with this. So you're between GABA and NMDA, and GABA is inhibitory, whereas NMDA is stimulatory. And since they're talking about calcium entry through something that would mediate the outcome of a competitive response, you could somehow start thinking this might be something stimulatory, but I still don't see anything online from explanations where they really mention something that kind of makes this easier. I'm going to try to find something and come back to this after my first 25 questions, and then when I start number 26, the next stream, I'll talk about this question first, because this is definitely a topic you want to know well. You want to make sure you understand the NMDA receptors, the GABA receptors. They're talked about a lot, especially when it comes to alcoholism and stuff, where NMDA receptors get kind of downregulated. So we'll come back to that. Let's just keep going for now. Number 7, a 68-year-old man who has been treated for the past 4 weeks with a new NSAID for rheumatoid arthritis has severe gastric burning and discomfort. A second drug decreases these adverse effects, but the patient develops severe diarrhea. The second drug most likely acts at which of the following sites? And then you look at this picture and you have to make sure you can identify all the different things here. So this is basically the same image you have in your GIT pharmacology. And this patient had NSAIDs for rheumatoid arthritis, but then got gastric burning because NSAIDs get rid of prostaglandin synthesis. So the gastric ulceration is possible. He is now on another drug that won't affect prostaglandin E synthesis, but it somehow caused diarrhea. Now you look at all your answer choices, right? A is acetylcholine. Acetylcholine blocker, so muscarinic antagonist against M3 such as atropine, right? That would be a medication you could put here. Atropine side effects do not include diarrhea. Instead, it would actually cause constipation, if anything. C, over here, a histamine blocker, so an H2 blocker like cimetidine, ranitidine, any of these guys. But its side effects include anti-androgenic effects and confusion, which other H2 blockers don't cause. D, over here, is blocking gastrin, right? A gastrin blocker isn't really a medication you have. It's not a real thing. E is working with the hydrogen potassium ATPase. That's your big guy for GERD, omeprazole, right? Omeprazole, which many would think would be a good idea, but remember, the goal is to treat his rheumatoid arthritis, not his gastric burning. His gastric burning is not due to excess acid production, but rather it was a side effect of NSAID use. Right? So a few people really wanted to pick E as the answer choice, but the correct answer here was B, right? The yellow one right here. And you can see this student also chose E as an answer choice because, when you have gastric burning and you have excess gastric acid activity or gastroesophageal reflux, you just use omeprazole. But you needed to make sure you remember that you're actually trying to treat this person's rheumatoid arthritis, and using an anti-inflammatory NSAID didn't really work. So now you can use misoprostol. Misoprostol, which is a PGE analog, is what is needed in this patient. He will continue taking the NSAID, but the misoprostol prevents the NSAID-induced peptic ulcers, which is the main issue that this patient is having. It is used off-label for labor. The side effects of this is diarrhea and abortion. So if we look at misoprostol, let's go to GIT pharmacology real quick. So they basically redrew this image, right, and they presented it in a different way to you. So misoprostol is right here. It's a PGE1 analog. It increases the production and secretion of gastric mucus barrier and decreases acid production. You can give this with NSAIDs to prevent NSAID-induced peptic ulcers, right? And that's basically all you had to do for this patient who's taking an NSAID for their rheumatoid arthritis. Adverse effects of this are just diarrhea. Misoprostol causes diarrhea. Right, the other thing you already know is an abortive fashion. You already know that part, so don't worry about trying to memorize that separately. Misoprostol causes diarrhea. And that's what this guy's issue was. Number 8. 70-year-old man with severe congestive heart failure has had progressive orthopnea for the past 4 weeks. He has not been taking his medications. During this time, his urine output has progressively decreased to 300 milliliters a day. So his urine output has decreased. We did a question on something similar to this yesterday too, from the same NBME. This is once again azotemia. We talked about azotemia yesterday. You have to remember there's pre-renal azotemia, which means something's occurring before the kidney itself, and there's also post-renal azotemia, which means there's some kind of obstruction after the kidney, right? And you need to make sure you understand that azotemia is related to fractional excretion of sodium. Let's go back and take a look at that one more time. Because as I said, repetition is the best way of memorizing stuff, and you should know acute kidney injury in such a way that you could talk about it without having to look at this page, right? That's the main goal for memorizing things. So AKI, defined as an abrupt decline in renal function, as measured by high creatinine or high BUN or lack of urine. Right? You're not going to make urine if your kidney is kind of messed up. There's pre-renal and post-renal, and then of course intrinsic renal failure. Pre-renal is due to decreased blood flow, hypotension, which can be due to severe burns, too much hemorrhage, anything. This leads to a decreased glomerular filtration rate. So you have sodium and water and urea retained by the kidney in an attempt to conserve volume. So your BUN is going to be high, right? Much higher than your creatinine. So this ratio gets tilted in the favor of BUN because urea is reabsorbing, creatinine is not. And your fractional excretion of sodium will be very low because you're going to keep all your sodium to retain water with it and manage your volume, right? So all you're thinking here in pre-renal azotemia is this guy does not have enough blood, so he's going to retain water to kind of manage the volume. Intrinsic renal failure is going to be something with tubular necrosis, anything that's really messing up your glomerulus, right? All of those typical things that we've done a lot of before. And the urine is going to have epithelial or granular casts, right? This is really the only time you kind of see these casts. Urea reabsorption is impaired, so now your BUN is going to be low as well as your creatinine, so the ratio will be low. So the ratio might be like 1, if anything, because they're both going to be pretty much not reabsorbed. And your fecal excretion, I keep saying fecal excretion, I've been doing that since like the first time I've ever even talked about this. Your fractional excretion of sodium is going to be very high, because again, you can't reabsorb shit, right? Post-renal azotemia is after the kidney, so there's some kind of obstruction. It can be stones in the ureter, it can be BPH, any kind of cancer, congenital anomalies, right? Develops only with bilateral obstruction or in a solitary kidney, right? So post-renal azotemia is pretty rare, right? You have to have an issue that's causing obstruction on both kidneys, or you only have one kidney and it got obstructed. Now our guy is a 70-year-old man with heart failure, right? He has orthopnea. He has not been taking his medications, and now his urine output is low. Alright, so this patient has unmanaged CHF, which is leading to more renin-angiotensin-aldosterone system due to low cardiac output, and that leads to more renal sodium and water reabsorption, hence the low urine output. Right, so this is pre-renal. Due to low renal blood flow, his BUN-CR ratio should be high, and his fractional excretion of sodium should be low, since he is reabsorbing all of it to manage his volume, and thanks to RAS. Right, so that would just be choice D. Choice D has a high BUN creatinine ratio, right? Urea nitrogen is high, creatinine is low, so this ratio would be like 40/2, so 20, right? Whereas in the others, you can see ratio is just a division, right? 10 divided by 1 is 10, 20 divided by 2 is 10, 30 divided by 2 is 15, 50 divided by 4 is also pretty low. That would be about 15 also, right? 15, 15, 30, yeah. So like 13 something. But 40 divided by 2 is 20, and that's the highest BUN ratio we have here, right? And then, on top of that, pre-renal azotemia, remember you're reabsorbing everything. So in your urine, you should not have much sodium. And you could tell this is the lowest amount of sodium in these answer choices. And specific gravity, you don't need to worry about too much. But again, specific gravity is 1.025. It's a little higher than normal, and that's all you work with, right? But specific gravity was just put in there to kind of throw you off. you could answer the question without really worrying about specific gravity. Alright, so pre-renal azotemia, very nice topic. They love, it's going to be on your step 1, it's going to be on your NBME. It's something you really need to understand. Just like for the heart, you need to understand heart failure. For the kidney, you need to understand azotemia, because that's renal failure, right? So same thing, same category, failure. Number 9, 44-year-old man with invasive pancreatic cancer is brought to the emergency department because of a 2-week history of severe right-sided back and abdominal pain. He states that he had a 15-pound weight loss during the past month. Physical exam shows no abnormalities. An operation is scheduled to relieve the pain. The most likely target of pain relief is which of the following labeled sites in the photograph of a myelin-stained cross-section of the spinal cord. So you need to identify all the different parts of the spinal cord, and this is something you should be very comfortable with. First of all, without even looking at the thing, you should also know which tract you're going to be thinking of. And as far as pain and temperature are concerned, that's your spinal thalamic tract. Now, back here are your dorsal columns. These are ascending fibers that are sensory, but not for pain. They're for proprioception and stuff like that. Right? So A and E are the medial ones. These are your gracilis for your graceful legs, and B and F are cuneatus. Those are the arms, right? So you think of a ballet dancer, and when you're doing like not just a ballet dancer, but even an ice skater, when an ice skater has to turn around, they have to close their legs in and open their arms out, and that's kind of what's happening here, right? So the legs are in, arms are out, and that's it. This is proprioception. G and C, those are your corticospinal tracts. Those are descending tracts that help with motor activity, voluntary motor activity. So it was between H and D now. H and D would be your spinal thalamic tracts, which cross in the middle right there at the white commissure. And you have to remember that the spinal thalamic tract is pretty unique in the sense that it crosses immediately, right? There's no decussation in the brain. It decussates in the spinal cord, whereas your corticospinal tract and dorsal columns, they decussate higher up in your brain. So now, where would the issue be for this guy? So they said that he had right-sided back pain. So you would do the right side, the left side, the H, right? Because remember I just said that it decussates immediately. That was the unique special part to this stuff. It was different from the others, so make sure you understand that. Corticospinal tract, dorsal column, those two, they decussate in the brain. But your spinal thalamic tract, I put here, the patient's spinal thalamic tract needs to be anesthetized, and those sensations are ipsilateral in the spinal cord, then they decussate. This is the spinal cord image. In the brain, the sensations are received contralaterally after the decussated fibers ascend to the contralateral VPL in the thalamus. So the correct answer here was H, which is this one here on the left, right? Because this is the one that's going to go bringing his pain, right? Severe right-sided back pain and all that stuff. Let's go take a look at it real quick, page 573. So you should be able to draw, not page 573, is it? What is it? 550. I don't know why I keep looking at the wrong page. You should be able to draw out your tracks really nicely. So our picture was related to these two things, right? This is the stuff you needed to identify. Okay, and we were looking at this, the spinal thalamic tract, which is this area right here. Right, and your spinal thalamic tract, remember, looks like this, and you can see how as soon as it enters the spinal cord, it decussates right there, and then it ascends contralaterally the whole time. Right, and this guy is the one that uses the spinal lemniscus, which is right next to the cuneatus. Right, so spinal lemniscus is like right here somewhere, next to this gracilis, cuneatus, and the spinal lemniscus right there. All right. So this is about sensation of pain, so it's definitely not A, B, F, E, which are all for the dorsal column. C and G is your descending tract for corticospinal tract. That leaves you with H and D, which are your spinal thalamic tract, the one that senses pain and temperature. Since the patient feels it on the right side, you anesthetize H because the spinal thalamic tract decussates in the spinal cord, unlike the dorsal column and lateral corticospinal tract, which both decussate at the medulla in the brain. Alright, so that's it for that. Number 10. This was easy. 45-year-old man is brought to the emergency department after being found unconscious in the desert. 24 hours ago, he had been hiking and lost consciousness after falling and striking his head on a rock. His pulse is 124 per minute and blood pressure is 80/40. He's mildly confused. Physical exam shows multiple ecchymoses on the upper and lower extremities and a large contusion on the left forehead. Which of the following best explains the hypotension? So he's been in a desert for 24 hours, which means not only did he not really drink any water, but he was also sweating like crazy. So he's very, very dehydrated, and this is hypovolemic shock. A lot of people thought the answer was D, increased intracranial pressure, because of his CNS injury, but that wasn't really relevant here. It's simple. He's just dehydrated, so he's going to have high blood pressure and a low PCWP and cardiac output. Just give him IV fluids. Done. Alright, don't overcomplicate it. They gave you all this injury stuff about the head contusion and all that shit, but it wasn't really relevant to the question they were asking, which is, why does he have hypotension? Excuse me. Okay. 11. An 18-year-old woman comes to a physician because of a 6-month history of progressive muscle weakness, poor exercise tolerance, and shortness of breath with exertion. She also has had difficulty following moving objects with her eyes, especially when she's tired. So she's like really young too, 18. Her pulse is 110, respiration is 22, blood pressure is a little low. Physical exam shows bilateral ptosis. Muscle strength is 3 out of 5 to 4 out of 5 in all extremities. Examination of a muscle biopsy shows abnormal accumulations of mitochondria in the subsarcolemmal regions, which is a giveaway for the fact that this is most likely some kind of mitochondrial disease. Which of the following additional sets of findings is most likely in this patient? The question stem is describing a mitochondrial disease, which commonly presents with lactic acidosis. There is an increase in anaerobic forms of energy production, like glycolysis. The mitochondria are faulty, so they cannot use the end product of glycolysis in TCA. Instead, pyruvate is now shunted over and used by LDH to generate, not pyruvate, lactate. The description of mitochondria in the subsarcolemmal regions is describing ragged red fibers. So now, looking at your answer choices, maximum oxygen consumption, venous blood lactate, and energy production by glycolysis. So you know for sure that venous lactate and production by glycolysis have to be high. Right, so that's your A answer choice and your E answer choice. That's basically it. So you're now down to a 50-50. And then maximum oxygen consumption. Again, your mitochondria are not working, so you're not going to consume a lot of oxygen at all. Your mitochondria is the one that uses oxygen, so you go with E, low. This student chose A, right? But oxygen consumption is going to be low in this patient because their mitochondria is not working. When it comes to mitochondrial disease, there's a lot of different weird ways they can bring it up. One of the 59. I gotta stop copying the number like that. One of the cool things is this thing here, mitochondria. When you look at it under Gomori trichrome stain, it shows like this, right? Because you're gonna see the red rim from the Gomori trichrome stain. Succinate dehydrogenase staining is also very sensitive for mitochondrial proliferation because you have it in the mitochondria. And Gomori trichrome is in this UWorld question. See Gomori trichrome stain? They mentioned it in UWorld in a question where the chance of inheriting the disease was 0% because the dad had it, and the dad does not give mitochondria to the children at all. All right. So MELAS, remember, lactic acidosis is DLA. 12. A 26-year-old woman comes to a physician because of a progressive itchy red rash on her arms over the past 2 weeks. She began working in an animal clinic 2 months ago. She says that she has not been bitten, but she was scratched on both arms while caring for a litter of kittens. Physical exam shows annular erythematous plaques with central clearing and advancing of scaly borders. No lymphadenopathy. Which of the following is the most likely diagnosis? So you can't really pick cat scratch disease here at all because they told you there's no lymphadenopathy. The defining feature of cat scratch disease from Bartonella henselae is lymphadenopathy. So you wouldn't pick that, right? This is not an atypical mycobacterial infection, nor is this disseminated toxoplasmosis. Toxoplasmosis, usually you want to consider like a pregnant woman or someone immunocompromised. And this is not psoriasis, right? Erythematous plaques with central clearing and advancing scaly borders. You could maybe think psoriasis here, but then they wouldn't give you all this extra information about scratches and shit. This is tinea corporis. Tinea, the physical exam is describing scaly rings of ringworm infection, which has central clearing like a target. The lack of lymphadenopathy cancels out cat scratch disease, which is a fucked up answer choice but a smart one to put in the choices. Tinea corporis can be acquired from pets or farm animals. Right, so don't fall for that shit. Think of NBME test writers as like really big trolls. They just love trolling you. They are going to have all kinds of baitful answer choices that want to confuse you. And, if you're like mentally exhausted, you see an answer choice and you're like, it must be that. Let me just pick it and move on. Don't do that. Alright, don't do that. You don't want to just pick it and move on, because that's a lot of points to lose from just picking something and moving on. What is happening? Why does it keep saying my video output is low? Let me just make sure it's HD. I'm just going to keep it HD, because I don't want you guys to not be able to read this shit. Okay, we're good. Stream health is low, whatever. Alright, 14. No, we're up to 13 now, right? Yeah, 13. Alright, 55-year-old man comes to physician because of a 1-year history of progressive shortness of breath. He recently retired after 30 years as a construction worker. He does not smoke. Bilateral basilar, fine, and inspiratory crackles are heard over the lung fields. A chest x-ray shows diffuse bilateral parenchymal opacities with a reticular pattern and bilateral diaphragmatic pleural plaques. The diaphragmatic pleural plaques are a giveaway for what's wrong with this guy. Microscopic examination of a sputum sample shows no atypical cells. Pulmonary function testing is likely to show which of the following sets of results in this patient. Alright, so he retired as a construction worker. So definitely related to that because he doesn't smoke. This is a pneumoconiosis. The pleural plaques are a giveaway for asbestosis, especially considering his presentation and work history. Pneumoconiosis presents with occupational history and lung findings unrelated to some kind of sickness like pneumonia. Pneumoconioses are restrictive lung diseases, which present with a normal FEV1 FVC ratio, but a low FVC since the lung is restricted. The DLCO decreases for the same reason as well. Right? Diffusion capacity for carbon monoxide has to be low. So once you understand that the diffusing capacity for carbon monoxide has to be low, you're really down to just A and D. And then you have to remember that the FEV1 FVC ratio is low in the other type. This is restrictive. The obstructive lung diseases, right? Obstructive lung diseases have a low FEV1 FVC. It's kind of the defining feature there. This is a restrictive one, so you just pick D. Normal FEV1 FVC, decreased carbon monoxide capacity, diffusing capacity. So carbon monoxide diffusing capacity is also low in one of the obstructive lung diseases as well. If we go to obstructive lung diseases, right, up here, remember that in chronic bronchitis, DLCO is usually normal, but in emphysema, DLCO is low because you have a destruction of alveolar walls. And then in asthma, again, DLCO will be normal. Right, but when you get to restrictive lung diseases, which includes all these other things, right, the one that we're looking at are your pneumoconioses, coal workers pneumoconiosis, silicosis, asbestosis, whatever. So when we look at asbestosis, right, you're supposed to have these calcified supradiaphragmatic pleural plaques. That's what this guy has. Our guy has asbestosis, and it kind of looks like, where is it? Like this, image A, right? The pleural plaques, supradiaphragmatic pleural plaques, right? Asbestos-related disease. If you get the whole lung encased in this kind of thing, that's mesothelioma. That's different. also related, but this guy just has asbestosis. Alright? So diffusing capacity of carbon monoxide in restrictive lung diseases, where is it? Let me go back to that. Right, it's going to be low. Interstitial lung disease, diffusing capacity is low. The only restrictive lung disease where DLCO is normal is in the ones where it's not interstitial, it's not related to the lung itself, but either you have poor muscular effort or some kind of body issue like your scoliosis or obesity. But interstitial lung disease, any interstitial lung disease, restrictive or obstructive like emphysema, you're going to have a decreased capacity of carbon monoxide to diffuse because you don't have functional alveoli that are just nice and moist. 14, a 44-year-old woman. Okay, so these 4 questions the student got wrong. So I didn't think these were hard, but let's take a look. 14, a 44-year-old woman, G2P2, comes to the physician for a health maintenance exam. Physical and pelvic exams show no abnormalities. The pap smear shows dysplastic columnar ciliated cells. If this patient were healthy, columnar cells seen on the patient's pap smear would most likely originate from which of the following areas. So they're basically asking you, where would you actually see columnar cells? So let's go take a look at this one section of female reproductive anatomy that you definitely want to make sure you have down, right? Female reproductive histology. So from the vulva all the way to the ovary, things change. From the vulva to the vagina to the ectocervix, everything is stratified squamous. In the transformation zone, you have squamo-columnar, right? Transformation zone. That means that the squamous stuff was before it, and then after that, everything's going to be columnar. That's your endocervix, right? Your uterus, fallopian tube, and then the ovary is unique. The ovary has simple cuboidal cells, which also often gets tested. And you have to understand that the ovary needs to be unique because the ovary breaks, it ruptures, and then it closes again, right? So that's why it has simple cuboidal cells. But your endocervix, all the way up to your fallopian tube, everything is columnar. And then everything from ectocervix, the outer portion, to the vulva is squamous. So in our question, the correct answer was the cervical canal. Right? This student chose this student chose vaginal portion of the cervix, but the vaginal portion of the cervix is your ectocervix. That would be squamous, right? The vaginal vestibule is also squamous. The posterior fornix of the vagina, again, if you're still talking about the vagina is squamous. Doesn't matter what portion of the vagina we're talking about, it's all squamous. And endometrium is, you're not even supposed to be wondering about that, because the endometrium is like the lining of your uterus. It's different. It's not really what we're trying to figure out over here. Right? That's much deeper in and a whole different thing. But basically, endometrium, you don't want to think endometrium and uterus are the same thing. Don't do that, because then yes, sure, you would have columnar epithelia there too, but they said, where is it? They said that they wanted just columnar cells. That's it, nothing else. Right? Columnar cells seen on the patient's pap smear would most likely originate from which of the following areas? It would come from the cervical canal. Female reproductive histology. The vulva to ectocervix have squamous epithelium because it gets damaged and sheds. Then the squamo-columnar junction leads to the endocervix, which has columnar epithelium up to the fallopian tubes. The ovary is cuboidal because it breaks and rebuilds. That's it. The endometrial lining depends on where on her menstrual cycle she is, and it would have glands and glycogen. Yeah, it's very true, Victor. I mean, even here, they love doing that, right? Because asking direct questions about individual diseases one at a time would supposedly be too easy, so they can't do that. Apparently, asking easy questions is a bad idea. Alright. 15. Which of the following best explains the impaired action potentials in the affected axons in patients with demyelinating diseases? Okay, so you look at all your asterisks. Cessation of the fast axonal transport, degeneration of the axon, which is what this guy chose, degeneration of voltage-gated calcium channels, depolymerization of axonal microtubules, or increase in axonal capacitance. Now, I can see why you would pick degeneration of the axon, because degeneration of the axon would impair action potentials, but they're only talking about demyelinating diseases. In a demyelinating disease, you do not degenerate the axon, you demyelinate it. Right? So that's something you want to make sure you understand. Don't read too quickly. 536. We talked about this a couple times, and this is a topic that NBME likes to pick on too, because it's slightly confusing and no one really teaches it a lot. But when I first taught this at the beginning of neurology, I mentioned that you want to just remember velocity equals distance over time, the same thing you've always used in physics. And velocity is quick, right? And if you have myelin, if you have a lot of myelin. So velocity equals distance over time. Distance, when it comes to myelin, is considered the length constants, and time is your time constants. A bigger length constant or a smaller time constant both mean more velocity. Demyelination decreases L and increases T, right? It decreases the length constant and increases the time constant, thereby lowering velocity. But our question is about capacitance. So I wrote over here, also remember, myelin speeds up nerve conduction by reducing the capacitance and increasing resistance. This is more of a electrophysiology kind of thing. It's like physics about electricity and magnets, if you ever studied that. And even if you did, you wouldn't remember it anymore. So it was kind of fucked up with them for them to put this as an answer choice, like capacitance and resistance. You know, how much do you really know about those things now in med school? But however, the other answer choices didn't make sense, so you could knock them out. Right? You're not gonna have cessation of fast axonal transport. That's another answer choice a lot of people wanted to pick. Right, but you don't cessate it. You don't end it. This is basically saying you stop doing axonal transport, and that's not true. You don't stop it, you slow it down. You don't degenerate your axons. You definitely do not degenerate any voltage-gated calcium channels, and there is no depolymerization of axons. That's the same thing as saying degeneration of axons. If the polymer is depolymerized, it breaks apart. Right, so after knocking all those out, you would just pick E. E is a mechanical engineering kind of thing. You know, it's like, why would you know this? So first aid does not teach about myelin in relation to capacitance and resistance, but it does discuss conduction velocity with respect to length and time constants. In general, myelin speeds up nerve conduction by reducing the capacitance and increasing the resistance. A capacitor, in engineering, is a device that stores electrical charge, like a battery. If you reduce capacitance, you reduce how much electricity is used, so the impulse gets transmitted rather than stored. Loss of myelin increases capacitance and causes the action potential to get stored rather than transferred. Alright, so you have an increase in action capacitance. So if you didn't understand, you can read it again. You could check out more about capacitors and resistors if you want, but that's a whole different thing. Probably not high yield at all. Just be able to knock out other answer choices. Alright, that's the best way to handle this. Also keep in mind, if you see something called the space constant is the same thing as your length constant. Alright. So the space constant is also known as the length constant and measures how far along the axon an electrical impulse can travel in a given amount of time. 16. A 47-year-old woman has had a goiter for 10 months. She has adequate iodine in her diet, and there is no family history of any thyroid disorder. Anti-thyroid peroxidase antibodies are identified in her serum. Serum concentrations of triiodothyronine and T4 are decreased. Her serum TSH is increased, which of the following is most likely involved in the pathogenesis of this disorder. So she definitely has hypothyroidism, which is why her TSH is high, and the anti-thyroid peroxidase antibodies are confirming that she has Hashimoto. So you look at all the answer choices. They wanted to know what is the pathogenesis of this disorder. E is the answer, replacement of thyroid parenchyma by lymphoid cells. You might not actually know that, but Hashimoto has Hürthle cells and lymphoid aggregates with germinal centers. That's something they actually teach in first aid. The other answer choices do not make sense. A, diffuse fibrosis of the thyroid is basically renal, right? Renal with fibrosis and inflammation due to IgG4 systemic disease, like autoimmune pancreatitis. Hyalinization and scarring of the thyroid parenchyma doesn't make any sense. Multiple giant cell granulomata throughout the thyroid parenchyma, that could be the curvain, because that's granulomatous. D, patchy areas of liquefactive necrosis, Again, why would you have liquefactive necrosis? That's not. Her thyroid isn't necrosing; it's being attacked. Replacement of thyroid parenchyma by lymphoid cells was the tricky way that they put the correct answer. So they love wording things in really fucked up ways, and it's pretty stupid that they do that. It's so unnecessary. So unnecessary. Just put the correct answer, man. Like, if I know it, I know it. And if I don't know it, then I won't see it, even if I read it the correct way. So this is Hashimoto right here. Hurtho cells, lymphoid aggregates, germinal centers. That's what you would see. Right, so the top over here, this is your normal thyroid. Right, and A is Hashimoto. So the arrow here is pointing at the hurtho cells, and you're supposed to see lymphoid aggregates and stuff. That's basically it. So we've already done this. We've done the endocrine chapter. We talked about all the different things in my endocrine videos. Just make sure you know they're different histologies. Alright, their different histologies are pretty significant. Their different presentations are significant, and there aren't that many. There really aren't that many. This page really only has two that you need to know very well. Is the subacute granulomatous decurvain and the Hashimoto. Alright, cretinism is a very easy question every single time. Renal thyroiditis is all thyroid that's really, really fibrosed. So it's solid. Fixed, hard, rock-like, painless goiter. The last one that the student got wrong on this page, number 17. This one was with this picture right here. When you see this picture, you should know the answer immediately, and they put the answer exactly the way you should be expecting to see it too. So if you're running out of time and you maybe have 30 seconds left, you see this picture, just pick fibromuscular dysplasia and move on. But this was a really easy question. 36-year-old woman comes to a physician for a follow-up exam 1 week after being diagnosed with severe hypertension. Her blood pressure is 180/120. Physical exam shows no other abnormalities. A CT scan of the abdomen shows a renal artery aneurysm. A renal angiogram is obtained from a femoral approach and is shown. Okay, which of the following is the most likely cause of these findings? And when you look at this angiogram, you can see the beating that's happening. Right, this is a renal angiogram. You're seeing beating. This is due to hypertension. She has fibromuscular dysplasia. This patient clearly has hypertensive emergency, right? 180/120, since she has end organ damage of her renal arteries, as evident in the angiogram. The image is just like the one in FA, with the string of beads appearance of the renal artery, and you can note microaneurysms. Pretty straightforward question, right? And it really is. It really is. We actually hoped all our questions are this straightforward, right? So here's I put that question into my first aid too, but here's the one that first aid has. Right, so you can see the beating that's happening. You can see the same beating in this beginning portion here. This is probably the aneurysm. Right, so don't get this wrong. Don't get fibromuscular dysplasia wrong. String of beads, usually female. 18 was also a question this guy got wrong, but I guess I can't really blame people for getting these questions wrong, but you should not. You should not. You should have these equations ready for yourself. You should master these equations. You want to make sure you get every biostatistics and epidemiology question correct. A cohort study is conducted to examine the association between cigarette smoking and lung cancer in a sample of 4,000 people. 1,000 participants smoke cigarettes and 3,000 do not. After 10 years of follow-up, there are 30 cases of lung cancer among the smokers and 30 cases of lung cancer among the non-smokers. According to these results, how many lung cancer cases attributable to smoking would be expected to occur in a group of 10,000 smokers over the same period of time? So they basically want you to extrapolate the information you just gained. You just did this on 4,000 people and you saw 30 people, right? Let me see. 1,000 participants smoke, 3,000 do not. After 10 years, 30 cases of lung cancer in the smokers, 30 cases of lung cancer in the non-smokers. How many lung cancer cases to smoking would be expected? Okay, so of those 1,000 people, that smoked, right, 1,000 participants smoked cigarettes, 30 of them got lung cancer. Now, this is simple incidence in exposed minus incidence in unexposed, right? We're calculating the attributable risk. So you do 30 over 1,000, that's 3% incidence in exposed and 30 over 3,000 is a 1% incidence in unexposed. So in 10,000, 3% would be 300 and 1% would be 100. And you need the attributable risk, the difference between the two. So 200 was the correct answer. Right? I totally understand how this guy got to 300, why this person might have picked 300. I get it, but you want to make sure that you understand the fact that this was attributable risk. Right? They wanted to know the risk. How many lung cancer cases attributable to smoking would be expected to occur in a group of 10,000 smokers over the same period of time? Right? Alright, 19 and 20 were not that bad at all. 19, again, you have your lung volumes, right? 63-year-old woman comes to the physician because of a 2-month history of progressive shortness of breath with exertion. Pulse is 80 per minute, respirations are 8 per minute, and blood pressure is 125 over 80. Physical exam shows no other abnormalities. Chest x-ray shows a mass pressing against the outside of the trachea just above the carina. Pulmonary function testing is most likely to show which of the following sets of results in this patient. So this is all about the respiratory flow volume stuff, and this patient has an obstructive defect due to the fixed obstructors, right? Some kind of mass above the carina. So inspiratory flow rate has to be lower, so that knocks out half of your options, right? Inspiratory flow rate, peak inspiratory flow rate cannot be normal. If you have a mass in your carina area, you're not going to be breathing in normally. Expiration also has to be slower, so that leaves only C or H, right? Where both things are low. Both things are low, C and H. FEV1 over FVC is low in obstructive lung issues, right? OLD. Obstructive lung disease has a low FEV1 to FVC ratio. At that point, you can just go ahead and pick H and you're done. FVC also will be low for this patient, functional vital capacity, which is hard to explain, but basically this patient's tidal volume is really low due to the abnormal breathing, but the ERV and IRV are unchanged, right? But you don't really need to worry about that part that much anymore once you understand that this was just an obstructive thing causing everything to decrease. And this actually can be shown as a curve too, so we haven't done the new respiratory videos. I think I talked about some of it in the old ones. But you need to make sure you understand tracheal stenosis. Right? Tracheal stenosis is kind of what this patient had, where both things are lower. Both things are lower. And right here, what we're looking at was basically more of the obstructive lung disease kind of thing. Right? And these are all your flow volume loop things you need to know in terms of various lung volumes. And you know, in a patient with obstruction right in the carina because of some kind of mass, some cancer or anything it might be, you're going to have obstructive lung disease, not restrictive. Restrictive is more of the lung itself, either because you have bad muscles or scoliosis or something interstitial inside the lung where your DLCO would also be low. Right? They didn't put DLCO on this chart, by the way, so make sure you understand that DLCO is pretty unique depending on what the actual issue is. In your obstructive lung diseases, emphysema is really the only one where your DLCO is low. In your restrictive lung diseases, anything that's interstitial, they're all going to have low DLCO. Right? Restrictive lung disease has DLCO always, except for the cases where your restrictive lung disease is related to your bad muscle or scoliosis or something outside the lung. Okay. So you were taught one more, right? The green one. The green one is the unique one that is not in first aid. There's many different curves, and you might not even know how to read these curves, so you want to make sure you spend some time learning it, right? You have an X and Y axis. You have to understand that there's a reason things are shifting the way they are. Now, I will tell you one last thing though before moving away from this page, because it always irks me. The normal standard curve that you draw should have a line here. Right? When you draw an x and y axis, your intersection is at the 0 point. Right? But you see how their y-axis is not at the 0 point. This is not 0. Your y-axis should have been here. It should have been here. I don't know why they draw it the way they do. I'm sure they have some kind of good explanation. I really hope they do. But I don't know why their y-axis is all the way over here, and then the x-axis goes like this, and you count backwards on it, like as if things weren't confusing enough already. So when you say the loop shifts to the left, usually when you say things shifting to the left, it usually means things are decreasing. But you can see here, when you shift to the left, your numbers are getting bigger. Okay, so it's kind of weird that they drew this the way they did, but I'm not important enough to actually challenge this, I guess. But I really don't see why you would draw it the way they draw it. Like, I don't get the point of that. That makes no sense to me. But they did that, so that's on them. Number 20, a 40-year-old man has had enlarging breast tissue for the past 3 months. He began taking a diuretic 6 months ago. Which of the following drugs most likely caused this? And spironolactone causes gynecomastia and antiandrogenic effects. That's just something you have to remember. Renal medications are not that hard. They take some time, but they're not that hard at all. They're probably the easiest of all the different pharmacology sections. Right? When you come to renal pharmacology, it's probably the easiest pharmacology section in the entire book. You need to memorize this shit, and you need to know each group of medications and how they work. Right? Especially ones that are, like popular, like thiazide diuretics, potassium sparing diuretics, loop diuretics. You need to know them very well. You need to know your water pill, the furosemide, right? You definitely need to know carbonic anhydrase inhibitors, because that's also something we talked about just recently when we did ophthalmology, right? So you need to know these really well, spend some good amount of time on them. It's a very easy chapter. Thankfully, they don't talk about any other pharmacology in renal pharmacology. It's literally just renal medications, so it's a good chapter. Make sure you know it. Make sure you know it very well. 21. An anti-serum is a list. Oh yeah, this was a cool question. So apparently this question was on UWorld too, but in a different way. So an anti-serum is elicited by immunization with protein X, and the anti-X antibodies are adsorbed to microtiter wells. The graph shows the amount of radiolabeled protein X bound by the anti-serum in the presence of varying concentrations of protein Y. With respect to the anti-X serum, which of the following interpretations of the epitopes expressed by the proteins X and Y is correct? So, as you can see, the y-axis is increasing amounts of Y being added, right? Amount of Y being added. And the x-axis is amount of labeled X that's being bound to the Y that's being added, right? But you can see that X is not being bound, right? This is staying the same. No matter how much Y you're adding, whether it was 1, 5, 10, right, 15, let's say there's some numbers here, you keep adding Y and you keep adding Y, but X is not binding to the Y. That means that proteins X and Y do not have any epitopes in common. That's what this was about. Apparently UWorld had a different question where the line was something like this. Right, so if you have this line, then the answer is A. Proteins X and Y express the same epitopes, where when you're adding Y, the more Y you add, the more X is binding to the Y. Right, so if the X is binding to the Y, that means they're similar. See, the anti-X antibodies have to bind the Y because it's sharing the same epitopes. That's basically all you're supposed to understand from here. And since UWorld and NBME both asked this question, you want to make sure you don't get this wrong. Alright, so it's either going to be A or B anyway. There's really no other way to ask this question. So either there's no change at all, or there's a continuous change, right? It's just reading a graph. Even if you don't understand what the fuck the graph is talking about. The black line here shows you no change, so that means there's no epitopes in common. The red line here shows continuous change, right, at a one-to-one manner. That means that they share the same epitopes, one-to-one. 22. A 61-year-old man is prescribed fluoxetine for major depressive disorder. Fluoxetine is an SSRI. This drug has its initial effects on neurons arising in which of the following structures? So serotonin, right? Serotonin is low in depression, and fluoxetine is a selective serotonin reuptake inhibitor that increases serotonin concentrations. Serotonin is synthesized in the Raphe nucleus of the medulla. How would you know that? Why would you know that? Well, it's actually in first aid, right? When you do the neurotransmitters, they tell you right here for serotonin, Raphe nucleus in the medulla. Right, so you definitely want to make sure you know that. We just did neurology, and even if you didn't do it with me, like, this is something you have to study and you have to know. From this page, you definitely want to make sure you remember that serotonin comes from the Raphe nucleus and norepinephrine comes from the locus ceruleus. Right? GABA comes from nucleus accumbens, and that's something that I think I learned from doing a lot of questions, but you do need to know the location of synthesis. You need to know for all of them. Right? So spend time, make sure you get it down, revisit this as many times as you have to, make flashcards, whatever helps you study it, and talk about it, and make sure you reiterate it to yourself, because you can't forget this. As you could tell, they love asking you stupid questions, and this is definitely a stupid question, but you need to know it. Right, so you see, as choice C here, locus ceruleus, that was norepinephrine. Right, your ventral tegmentum and substantia nigra quars compacta is for dopamine. That one everyone remembers. Nucleus accumbens is GABA. Basal nucleus of Maynard is acetylcholine. 23. A child with septicemia has an antibiotic clearance of 0.09 liters per hour per kilogram. As soon as you read that, you're probably already intimidated, and then you're like, fuck, I'm just going to skip this question. The steady state serum concentration for the antibiotic is 12 micrograms, which further pisses you off, right? Because now they changed it to micrograms per milliliter, and the original thing here was liters per hour per kilogram. So 0.09 kilogram, okay? Which of the following is the maintenance dose in milligrams per kilogram per day? So not only are you trying to figure out maintenance dose, which is the easier part, you have to change up all the units, right? This is a dosage calculation. They are being mean by messing up the units, liters and milliliters. So 1 liter is equal to 1,000 milliliters. So 0.09 liters, right? This thing, 0.09 liters is actually 90 milliliters per hour per kilogram. And maintenance dose is calculated by Cp times Cl times tau divided by F. And we are told this medication is given once a day, so tau is 1. Right? Also, it seems like F is also just 1 because it's an antibiotic, which is usually oral. The next messed up unit is hours and days. So 24 hours equals 1 day, right? And they want the answer in days. Thus, 90 milliliters per hour per kilogram times 24 hours a day, right? You cancel out the hours units, and you get 2160 milliliters per kilogram per day. The next and last messed up unit is micrograms and milligrams, right? They put the serum concentration stuff in micrograms here. So 1,000 micrograms is equal to 1 milligram. So 12 micrograms divided by 1,000 micrograms, right? You cancel the micrograms out, you get 0.012 milligrams per milliliter, right? Because there's 1,000 micrograms per milligram. Now you just multiply everything and you get 28.8. But that was the hard part, right? So getting the units down. But you have to be calm with it. You have to understand how to actually change units. So 12 micrograms per milliliter divided by 1,000 micrograms per milliliter. Sorry, 1,000 micrograms per milligram fixes up the units by canceling out the micrograms and making it all milligrams. Once you fix up all the units, you get your numbers correct. They gave you the right numbers, Cp, Cl, and you just multiply the two. 25.92 was the answer you end up getting, and 28.8 is the closest thing, so you just pick it. Really dumb question though. 24. A 22-year-old man is brought to the emergency department 30 minutes after a friend found him unconscious on the floor. A drug overdose is suspected. His pulse is 120, respirations are 4, very, very low, with apparent low tidal volumes and blood pressures. Blood pressure is 120. Physical exam shows mild cyanosis. He's really not breathing. He has respiratory depression. Physical exam shows mild cyanosis. He's intubated and mechanically ventilated with positive pressure ventilation using 10 centimeters water, positive and expiratory pressure, PEEP. Which of the following sets of findings best describes the effects of mechanical ventilation with PEEP on this patient's alveolar and intrapleural pressures. So this is a topic that I will be teaching when I do physiology, but it's really, really annoying. I mean, you have your alveolar pressure, you have your intrapleural pressure. These are things that the book doesn't really teach that well, and I didn't really learn it in med school that well either. But they really just wanted you to tell them, which of the following sets of findings best describes the effects of mechanical ventilation on the alveolar and intrapleural pressure. So mechanical ventilation is there to help you breathe. So you want to pick the answer choice that tells you the things that would help you breathe. Your peak inspiratory alveolar pressure should be positive. Your end tidal alveolar pressure should also be positive. Your peak inspiratory pressure should be positive, and the end tidal should also be positive. Almost no one that I did this with wanted to pick this answer choice. They just didn't know about it. And the student that did this form, I actually don't know how they got A. I don't know if this student actually knew or just, gave up on life and just chose A and moved on. Could be any one of those things. But everything needs to be positive for you to be able to breathe correctly due to literally it's called positive pressure ventilation, right? Positive and expiratory pressure. Everything has to be positive, right? Nothing is zero. And that's kind of how you end up helping breathe in. It's a very weird topic. And these are some of the images that kind of talk about it. So when I get to here, and I think I talked about it in my current respiratory videos too, but when we get to this area of my current playlist, I'll talk about it again. I'll discuss stuff related to PEEP too, because PEEP is apparently something you need to know, which is really annoying. It's very unfair that they talk about this kind of stuff though, because it's not really stuff you learn as far as step 1 prep is concerned. Last question for this video, 25. A 60-year-old man has had easy fatigability, loss of appetite, and significant weight loss over the past 3 months. Routine studies show a marked increase in serum calcium concentration. Radiographic examination does not show bone metastases. This patient is most likely to have a cancer of which of the following organs? So fatigability, loss of appetite, weight loss, increased calcium. So that sounds like PTH-related peptide, right? As soon as you see PTH-related peptide in cancer, you're thinking squamous cell carcinoma. Small cell carcinoma does everything else, but squamous cell carcinoma of the lung is the one that makes parathyroid-related peptide. It acts like parathyroid hormone and increases calcium concentrations. Radiographic exam does not show bone metastases, which was just a bullshit sentence to put in there, and his cancer came from the lung. That's it. Alright? So that's it for that. In the next video, I'll come back and revise question number 6 first, so that we can talk about neurotransmitter receptors, and then we'll wrap up NBME 23, block 4. Thanks a lot for joining, and I hope that these videos have been very helpful.